Hello, it's Eric from Strong Medicine, and today I'm discussing an approach to the red eye. This topic could easily encompass a third of ophthalmology, but this particular video will just cover the highlights of what a non-ophthalmologist needs to know about this presentation, including when a patient needs to be emergently referred to an ophthalmologist. To best understand pathology of the eye, it's first necessary to have an understanding of its anatomy, which I'll review in brief, focusing on the parts of the eye that are most relevant to this discussion. When viewed from the front, in between the upper and lower lids, from a distance, the eye appears to have three main components. There is the pigmented ring, known as the iris, the pupil, which is literally just a hole in the middle of the iris, and which lies immediately anterior to the lens, and the white zone that surrounds the iris, which is called the sclera. As you can see in the top-down view, the sclera actually wraps around the entire globe of the eye. It's not just in front where you can see it. What might not be immediately apparent without close inspection is that the iris and pupil are covered by a transparent dome structure, which is the cornea. The sclera and cornea are contiguous. The region where one transitions into the other is called the limbus. The space between the iris and the cornea is called the anterior chamber. The posterior chamber is immediately behind the iris. Adjacent to the iris is the ciliary body, which has two main functions. It controls the shape of the lens, allowing the eye to focus on objects based on their distance, and it produces a clear plasma-like fluid called aqueous humor that fills the posterior and anterior chambers. The iris, combined with the ciliary body and a highly vascular layer beneath the sclera called the choroid, together comprise what is known as the uvea. In common usage, the term iritis, or inflammation of the iris, is used interchangeably with anterior uveitis, or sometimes just plain uveitis. Let's take a closer look at the anterior surface of the eye. What we commonly think of as just the sclera is actually composed of multiple layers, the outermost of which is not the sclera at all, but rather a thin membrane called the conjunctiva. Beneath the conjunctiva lies the sclera, but the sclera itself has several layers. The outermost is the episclera, then the sclera proper, also known as the scleral stroma, which gives the sclera its opaque white color, and then the lamina fusca, which is adherent to the choroid underneath. Even though the episclera is part of the sclera, the term scleritis refers to inflammation of the sclera proper, while episcleritis refers to inflammation of only the episclera. With the anatomy review complete, let's discuss a diagnostic framework for the red eye. The most obvious one is based on the anatomic structures just discussed. So let's start with conditions of the eyelids and work our way inward. A stye, also known as a hordeolum, is a bacterial infection of an oil gland of the eyelid. It's kind of like a pimple of the eyelid, but more uncomfortable. They can be either internal or external. They usually develop acutely. A stye should be distinguished from a chalazion, which is a cyst in the eyelid due to a blocked oil gland, but without infection or inflammation. So these are usually painless and usually develop subacutely. Blepharitis refers to inflammation of an eyelid. Blepharitis tends to be more of a chronic rather than acute problem. In contrast to blepharitis, periorbital cellulitis is an acute infection of the eyelid and surrounding skin and soft tissue, but without involvement of the orbital fat and extraocular muscles, in which case it would be orbital cellulitis. Periorbital cellulitis is often referred to as preseptal cellulitis, in which the septum refers to a tough fibrous membrane that separates the orbital contents from the overlying soft tissue. The next category in our framework is the conjunctiva and sclera. And when we talk about this category, we will need to start discussing the pattern of redness, also known as hyperemia. Moving superficially to deep, we start with conjunctivitis, which is inflammation of the conjunctiva, usually due to infection or allergy, but can also be caused by chemical exposure, including fumes and smoke. Depending on the etiology, pain can be absent to mild in severity, and vision is not usually affected. However, conjunctivitis from Neisseria, while a bacteria, deserves a separate listing because of its hyperacute onset, copious purulent discharge, frequent coexisting urethritis, and the potential for vision loss. As a general rule, redness or hyperemia in conjunctivitis is diffuse, meaning affecting all parts of the whites of the eye, except for sometimes having a relative sparing immediately adjacent to the limbus, which we can see in this example of viral conjunctivitis. Different etiologies of conjunctivitis can have slightly different appearances. The hallmark of bacterial conjunctivitis on exam is a thick purulent discharge. Again, we also see the relative sparing of the perilimbic region. And in allergic conjunctivitis, one can see edema of the eyelids in addition to the inflammation of the conjunctiva. As mentioned earlier, episcleritis is inflammation of the episclera. It is most commonly associated with relatively mild pain and no vision changes. It can be identified on exam by the radial pattern of the episcleral vessels, and unlike conjunctivitis, it is typically focal. For example, in this case, it appears to only be affecting the eye lateral to the cornea. Scleritis is inflammation of the sclera proper or scleral stroma. This is more painful and can compromise vision. Scleritis and episcleritis can visually look very similar on exam. The distinction between the two relies on the presence and severity of pain, the acuity of onset, whether the engorged vessels can be moved with light pressure from a cotton bud, and the effect of topical phenylephrine and/or topical anesthetics. A subconjunctival hemorrhage can be disturbing for a layperson to see in the mirror, but it is almost always a benign, self-limited rupture of a superficial vessel. Whereas with most etiologies of a red eye, you can distinguish individual blood vessels, with a subconjunctival hemorrhage, the blood is primarily confluent, being trapped between the conjunctiva and episclera. The hemorrhage is usually spontaneous and idiopathic, but can be triggered by sneezing, coughing, vomiting, and straining during bowel movements. It can take several weeks to fully resolve. A situation in which a subconjunctival hemorrhage may not be benign is when it's circumferential around the entire cornea, which suggests trauma and possible rupture of the globe. Dry eyes is pretty much what it sounds like, a reduction in the normal tear film that lubricates, nourishes, and protects the conjunctiva, sclera, and cornea. On conventional inspection, it can look very similar to conjunctivitis, but when severe and/or long-standing, it can be associated with surface defects of the cornea or conjunctiva that are visible with the application of fluorescein dye. Speaking of the cornea, this is the next anatomic category in our framework. Corneal abrasions are defects on the corneal surface, usually from trauma, including foreign bodies. The cornea is richly innervated with sensory pain fibers, so affected patients present with moderate to severe eye pain and a foreign body sensation, even when the foreign body is not actually present. Abrasions are best seen after application of topical fluorescein. Foreign bodies embedded in any portion of the eye can cause eye redness. Most patients can sense that there is something in the eye. As apparent in this picture, a foreign body can be very small and still cause problems. Working with power tools, leaf blowers, and weed whackers without eye protection are risk factors. Foreign bodies can also be found in the conjunctiva, but they are an incrementally bigger problem in the cornea. Keratitis refers to inflammation and/or infection of the cornea. On gross exam, this can appear similar to conjunctivitis, but in this example we can see a thin band of red from extremely fine vessels that encircle the cornea. This is known as ciliary flush, and it is not present in uncomplicated conjunctivitis. Keratitis can also present with white spots or gray branching opacities on the cornea, both of which are easier to see with fluorescein and with a slit lamp exam. This is an example of herpes simplex keratitis as viewed under cobalt blue light after application of fluorescein. And here's what the slit lamp exam looks like. And what keratitis looks like during the slit lamp exam, where you can see tiny granular infiltrates within the cornea, below the epithelium, that could never be spotted with a conventional pen light and the naked eye. And before we move off of corneal etiologies of a red eye, I'll mention that contact lens use is associated with a number of pathologies already mentioned, including keratitis. Last, we have 4 potential problems within the anterior chamber. Acute angle closure glaucoma occurs when drainage of aqueous humor from the anterior chamber is blocked, resulting in an increase in eye pressure. Symptoms include profound eye pain and decreased visual acuity. On exam, the pupil will be mid-dilated and fixed. The pupil may appear cloudy due to haziness of the cornea, and there is ciliary flush. Anterior uveitis is inflammation of the anterior portion of the uvea, that is, the iris plus or minus the ciliary body. In this example, we can see the ciliary flush that was also present in one of the examples of keratitis. And although the dilated pupil is uncommon in uveitis, we can see that it's irregular, suggesting a problem within the anterior chamber. Anterior uveitis is often associated with systemic inflammatory diseases, including autoimmune disease. Posterior uveitis and panuveitis also exist, but are less common. There are two more important problems of the anterior chamber that aren't so much diagnoses themselves as they are exam findings seen in the context of other problems. Hyphema refers to bleeding within the anterior chamber, often associated with trauma or inflammation. And last, hypopion is a layering, milky exudate within the anterior chamber, rich in white blood cells, often associated with keratitis or a condition called endophthalmitis, which is inflammation, usually from a severe infection, of the entire globe or eyeball. Here's the entire diagnostic framework for the red eye. The most common etiologies include viral and allergic conjunctivitis and dry eyes, luckily all of which are relatively benign. And those etiologies which require either emergent or urgent ophthalmological referral, which includes scleritis, some cases of corneal abrasion and foreign body, keratitis, and any pathology involving the anterior chamber. Diagnosing the etiology of a red eye usually depends only on the history and ophthalmological exam. Unless systemic disease is suspected, a head-to-toe exam and labs are usually not necessary. Let me run through the key questions to ask on history. What is the time course, specifically the duration of symptoms and whether it had an abrupt or gradual onset? Are the symptoms unilateral or bilateral? Is there pain, and if so, how severe is it? Is there noticeable vision loss? Keep in mind that patients do not always notice modest unilateral vision loss until it's pointed out to them during testing. Is there photophobia? Is there a sensation of a foreign body? This suggests a corneal process such as an abrasion and/or a literal foreign body, particularly if the patient is unable to open or keep their eye open. If possible, a foreign body sensation should be distinguished from grittiness or scratchiness, which can be experienced in conjunctivitis. Is there eye discharge, and if so, what is it like? For example, watery versus purulent. Is there a history of eye trauma or relevant occupational history that could result in corneal injury, such as construction, metal or woodworking, or landscaping? Does the patient wear contact lenses? And what is the patient's past medical and surgical history? Specifically, is there a history of prior eye surgery, autoimmune disease, or is the patient immunosuppressed for any reason? With the ophthalmological exam, you should start with a visual inspection of the external eye. This should include assessing the pattern of hyperemia. For example, is there ciliary flush, or is the perilimbic region relatively spared? Is there discharge visible? What is the pupil size and reaction to light? Is there a foreign body present? This includes assessment of the underside of the lids. Is there hyphema or hypopion present? And if there is suspicion of a corneal process, application of fluorescein can be helpful to visualize it. Assess visual acuity in each eye. Check movement of the extraocular muscles. Although none of the diagnoses listed in the framework directly cause problems with these muscles, per se, pain with eye movement is a feature of scleritis, and impairment of an extraocular muscle might suggest a more serious infection than discussed here, such as orbital cellulitis. If it's available, a slit lamp exam can provide greater magnification and detail than plain inspection with a pen light, but it is not usually necessary to simply identify a situation in which an ophthalmologist is needed. If glaucoma is suspected, the intraocular pressure should be measured, though this is usually only done by ophthalmologists. A fundoscopic exam, it's generally not necessary to diagnose most etiologies of red eye, and due to photophobia, most patients with a red eye do not tolerate it well. A word of caution: during the exam, if glaucoma is suspected, do not dilate the pupils or administer phenylephrine, as this will acutely worsen their condition. As mentioned, additional exam maneuvers and diagnostic testing should be performed only if there is specific suspicion for systemic disease. However, an important exception is taking cultures and considering general STI screening in suspected chlamydial or gonococcal conjunctivitis, as these will require different antibiotic regimens, frequently coexist with sexually transmitted disease, and may require concurrent treatment of the patient's sexual partners. There are a number of red flag findings during the exam which would warrant either emergent, meaning immediate, or urgent, meaning within 24 hours, ophthalmological consultation, because they suggest a diagnosis that involves either the anterior chamber or cornea, which could threaten the patient's vision. These include decreased visual acuity, a non-responsive pupil, hyphema or hypopyon, corneal opacity, a corneal abrasion that is large or one that is not healing after 3 to 4 days, a foreign body that cannot be removed with irrigation and cotton swab, ciliary flush, and moderate to severe pain or photophobia. I'll end the video by reviewing the major features of common and important diagnoses in table format to help with comparison between similar presentations. I'll start with 4 relatively benign causes of conjunctival pathology. Viral conjunctivitis is most common in children, and adenovirus is the most common cause. Pain is absent to mild in severity. It can be unilateral or bilateral. Eye discharge is watery. Visual acuity is normal. Viral conjunctivitis can present with a coexisting upper respiratory infection, and on exam, there is no corneal involvement. The microbiology of bacterial conjunctivitis depends upon the age of the patient. In children, Strep pneumoniae and H. flu are the most common, while in adults, Staph aureus is the most common. Uncommon but important causes of bacterial conjunctivitis, as recently mentioned, include chlamydia and Neisseria gonorrhoeae, which can occur in adults and neonates. Pain in bacterial conjunctivitis is absent to mild. It can be either unilateral or bilateral. A hallmark feature of this diagnosis is copious purulent discharge. Patients will sometimes report that their affected eye feels glued shut in the morning when they wake. Despite this, visual acuity is normal. Patients can have a foreign body sensation. On exam, no corneal involvement. Allergic conjunctivitis is caused by a type 1 hypersensitivity reaction due to airborne allergens. Pain is absent or mild. It's bilateral. Discharge is watery. Visual acuity is normal. Patients can report itching eyes or a gritty sensation. On exam, once again, there is no corneal involvement. Last in this category is dry eyes, which has a number of causes, including medications, notably anticholinergics and antihistamines, contact lenses, the autoimmune condition Sjogren's syndrome, post-laser eye surgery, or from infrequently blinking, for example from staring at screens too long or too intently. Pain can range from absent to moderate depending on whether there is corneal involvement. It's usually bilateral. There is often paradoxical watery discharge. Visual acuity can be normal or decreased. Patients can report foreign body, gritty, or itchy sensations. And in this case, on exam, there can be sometimes concurrent corneal pathology. And then there are 4 more diagnoses. Since they can superficially look similar, I'm going to compare and contrast episcleritis with scleritis. They both can be caused by systemic autoimmune conditions, though this seems more common in scleritis. Scleritis can also be post-surgical. Pain in episcleritis is either absent or mild in severity, but the onset is acute, whereas the pain in scleritis is moderate to severe, but comes on more gradually. Also with scleritis, pain is worse with eye movement. Visual acuity is normal in episcleritis, but can be either normal or decreased in scleritis. Episcleritis is associated with a grittiness and aching in the eyes, more so than pain. Patients with scleritis can experience photophobia, fever, and headache. Regarding the exam, in episcleritis, the affected area is bright red, and vessels can be moved and blanched with topical phenylephrine. And if pain is present, it improves with topical anesthetic. In scleritis, the affected area may appear bluish to violet, vessels are immobile and do not blanch with phenylephrine, and pain is unaffected by topical anesthetics. As the scleral stroma is contiguous with the cornea, concurrent peripheral keratitis may be present. Moving on to anterior uveitis, it is associated with many infections and systemic inflammatory conditions, most notably sarcoidosis, Behçet's disease, spondyloarthritis, and inflammatory bowel disease. The pain from uveitis is moderate to severe. Visual acuity can be either normal or decreased. Patients will usually have photophobia. On exam, the pupil will be constricted or irregular, and there will be ciliary flush. A distinctive and memorable finding is consensual photophobia, which is when pain is triggered in the affected eye by shining a light in the unaffected eye. And last, the most acutely serious diagnosis I've discussed in detail today is acute angle closure glaucoma. Risk factors include family history, age over 60, female sex, farsightedness, and a variety of medications, including adrenergic agonists and anticholinergics. The pain from angle closure glaucoma is moderate to severe, and visual acuity is usually decreased. Patients can report photophobia, halos around lights, and may have nausea and vomiting. On exam, there is a fixed mid-dilated pupil, ciliary flush, and corneal edema and/or cloudiness. That's it for this video on an approach to the red eye. The key takeaway points. There is a wide variety of pathologies which can cause an acutely red eye, which range from benign and self-limited to severe and vision-threatening. Determining the diagnosis of a red eye typically only requires a good history and thorough ophthalmological exam. Indications for emergent or urgent consultation with an ophthalmologist include decreased visual acuity, a non-responsive pupil, hyphema or hypopyon, corneal opacity or large non-healing abrasion, a non-removable foreign body, ciliary flush, and moderate to severe pain or photophobia.